Right. Okay. Now, if we are to go to the first question, right? First question. So this is it, right? A 1-year-old, well-looking child presented with reduced weight gain according to growth chart. We have RCPCH growth charts that are used in the United Kingdom. So we plot the child's growth in those growth charts. So this 1-year-old child was found to be having slightly low weight gain. Child is otherwise active. A routine physical examination revealed a systolic ejection murmur or ejection systolic murmur at left, middle, and upper border, right? With wide splitting and fixed second heart sound. The best management option for this child's suspected heart disease would be. Right. Please read the question again. It is just like online exams. This is how the exams are held. Just like this, you need to choose the answer. Okay, I know you might be a pre-intern doctor, you might be a post-intern doctor, you might be a registrar, you might be a senior registrar, you might be a cardiology trainee, or you could be a consultant. Depending on who you are, the knowledge might be different. But just to have a rough idea about what we have to know in cardiology, right? What we have to know in cardiology. Now, to say that I'm good in MRCPCH cardiology, what are the major areas that we should cover? If you have a piece of paper, right? If you have a piece of paper, you can keep writing this so that we will have a better idea about what we are supposed to know in this area, right? It is not just knowing the answers for these questions, but to get a broad idea about cardiology, right? Now, what are the major areas that we are going to cover? We will discuss acyanotic heart diseases, right? So that is one of the major topics we can write, the major areas in pediatric cardiology for MRCPCH. So the first subtopic is acyanotic heart diseases. So that is something that we will be doing. And then we will discuss some cyanotic heart problems, right? Cyanotic heart diseases would be the second main area, right? Second main area is cyanotic heart disease. So the first one is cyanotic heart diseases. The second one, cyanotic heart diseases. Then we will discuss quickly about heart failure, right? We will discuss about heart failure. And then we will discuss what? Acquired heart diseases. That is where we discuss about rheumatic fever, infective endocarditis, and a little bit of Kawasaki, myocarditis, those. So that would be our fourth topic, acquired heart diseases. And then we would discuss a little on cardiac arrhythmias, right? Cardiac arrhythmias, common ones, and their management. And then we will discuss a very little on some syndromes associated with heart diseases, right? Some syndromes associated with heart diseases, and then it will be miscellaneous, right? So summary. So what we discuss today will be acyanotic heart diseases, cyanotic heart diseases, heart failure, acquired heart problems, right? And then cardiac arrhythmias, some of the syndromes associated with heart problems, and then miscellaneous, right? So we will go in fairly in that order, right? Okay, so to begin with, 1-year-old child presented with slightly reduced weight gain, I would say. Child is otherwise active. Routine physical examination revealed a systolic ejection murmur or ejection systolic murmur, left, middle, and upper sternal border, with a wide splitting and fixed second heart sound. Best management option for this child's suspected heart disease would be, right? So we will be discussing around 20 questions. If you get say 5 marks for each question, you will get 100 marks. So at the end of the day, you will see how many marks you will get for cardiology. You'll take it as a test, right? Okay, now this question doesn't say anything about cyanosis. So very likely this is an acyanotic heart disease, right? This is likely to be an acyanotic heart disease, right? When you say acyanotic heart disease, what are the possible options to consider? If we don't know what the options are, we might not know what the best management is. We need to know the possibilities. Once you know possibilities, we know what the best management is going to be, right? So when a child comes with a heart problem but no cyanosis, then it is an acyanotic heart disease in general. So what are the possibilities? It could be an ASD, VSD, we can write them ASD, VSD, it could be a PDA, right? ASD, VSD, PDA. Then what are the other possibilities? It could be coarctation of aorta, right? It could be coarctation of aorta, right? Then what are the other possibilities? All the other valvular heart problems like aortic regurgitation, aortic stenosis, pulmonary regurgitation, pulmonary stenosis, mitral regurgitation, mitral stenosis, tricuspid regurgitation, tricuspid stenosis. So they are acyanotic, right? Now, how do you differentiate these heart problems? By just looking at the physical findings. Now, this child, what is he having? An ejection systolic murmur at left upper and middle sternal. So if you say left upper, what area is this? It is pulmonary, isn't it? It's pulmonary area. So this is an ejection systolic murmur at pulmonary area. When you say pulmonary area, what are the possibilities? This could simply be a problem of pulmonary valve, pulmonary artery itself. So could that be pulmonary stenosis? Possible, right? Pulmonary stenosis is possible. What are the other pulmonary murmurs, right? What are the other causes of murmurs to appear in pulmonary area? This could come as a separate MCQ. So pulmonary ejection systolic murmurs could occur due to pulmonary stenosis. What are the other possibilities? This could be an ASD. ASD also causes a pulmonary ejection systolic murmur. And then this could be tetralogy of Fallot as well. However, tetralogy of Fallot is a cyanotic heart disease, so it can't be the case here, right? Then what are the 2 common possibilities? This child might have pulmonary stenosis, or this could be an ASD, right? Out of 2, if we go by MRCPCH theory level, right, little more than undergraduate level, so then the possibilities are still either it is pulmonary stenosis or it could be ASD. And then what is the other physical sign that they are talking about? Fixed splitting of second heart sound, right? Fixed splitting of second heart sound. So fixed splitting of second heart sound for MRCPCH theory level is until proven otherwise ASD, right? ASD. So if you have a pulmonary ejection systolic murmur and fixed splitting of second heart sound, it is an ASD, right? So this child is likely to be having an ASD. Then what? He is otherwise active. Physical examination is otherwise normal. They are not talking about any heart failure, anything like that. So what kind of ASD is this? This is very likely an asymptomatic ASD, right? This doesn't look like making any problem to child, right? So there is reduced weight gain, but it is very unlikely that it is due to ASD itself because the child doesn't have any other features of heart failure here, right? So in summary, this 1-year-old child is likely to be having an asymptomatic atrial septal defect. So what is the question? How are you going to manage this question? So manage this child, or what is the best management? So what is this? Simply testing whether we know the management of uncomplicated atrial septal defect, right? So one of the theories, one of the areas that we have to know is ASD needs closure, right? They generally are not closed naturally, not like VSD, right? ASD will not close by its own, so it will need closure, right? Now, when it comes to closure, what are the two options? Either you can surgically close it or you can do device closure. Out of two, device closure is the most popular one, especially for ostium secundum ASD, right? So very likely this child would benefit by a device closure. Then we need to know what the timing for device closure. Here, the child is asymptomatic. Therefore, there is no need of closing this urgently tomorrow, day after tomorrow. You don't have to send the child to Evelina Hospital, London for cardiology opinion or King's College. No, you don't have to, because child is currently asymptomatic, right? Child is currently asymptomatic. So asymptomatic ASDs do not need urgent closure, but they will need closure at some point, right? They will need closure at some point. So urgent surgical closure is wrong. Reassuring the mother, right? Now, when you see a child with a murmur, we generally reassure if you think that murmur is functional. Do you think that this murmur is functional? Answer, no, right? Answer is no. Now, we might get a different question in MRCPCH paper with a functional murmur. What are the features of a functional murmur? Functional murmurs are always systolic, right? They generally are heard at pulmonary area, right? They generally are heard at pulmonary area. Therefore, this could be functional if you talk about these two findings only, because this is pulmonary area, left upper sternal is pulmonary, and it is systolic. But what? Functional murmurs generally do not have other abnormal physical findings. Now, this child is having fixed splitting of second heart sound that you don't get in functional murmurs. So this is not a functional murmur. If it is not a functional murmur, reassuring the mother would not be the best thing, right? You can reassure the parents or patient if he is old enough, if it's a functional murmur, because this is not a functional murmur. Sorry, reassurance is not the best thing to do. Assessing the child's feeding. You can assess feeding, right? Because we have some concern about reduced weight gain, but that is something that you would anyway do as a registrar or as a senior house officer. However, is that the best management option for this child's suspected heart disease? No, right? Assessing feeding is correct, but that is not the best answer. Transcatheter ASD closure. Transcatheter ASD closure, is that something that we can consider? Yes, we can consider that. But do you want to do it urgently? Tomorrow, next week? You don't have to. The question doesn't ask whether you want to do it urgently either. So this is one of the best answers out of 5. Then balloon valvuloplasty. We do balloon valvuloplasty in stenosis, narrowing of the vessels or valves. Here there is no narrowing. We don't suspect pulmonary stenosis here. Therefore, balloon valvuloplasty would not be the best answer, right? Balloon valvuloplasty would not be the best answer. So out of all 5 answers, the best answer here should be transcatheter ASD closure. Right. So this is simply an ASD. You see, this is the normal heart, right? So all these chambers are very well demarcated. Whereas in ASD, you can see there's a defect in atrial septum, right? It's fairly undergraduate, but we have to know them very clearly, right? So ASD, what happens is there is this defect in the atrial septum, right? Atrial septum. Now, if we just remember why they get ejection systolic murmur, it is like this. Now, because you have a defect, there is blood flow from left to right, left to right. Therefore, this, I would say, dirty chamber, right-sided chambers will be mixing with good blood. Good blood. So good blood will come to dirty chamber. But dirty blood will not go to good chamber. Dirty blood will not go to good chamber. Therefore, good chamber will not get dirty. So you don't get cyanosis, right? You don't get cyanosis. The reason why you don't get cyanosis is because this is left to right shunt, not a right to left shunt. And then what has happened, because of this defect, the blood is going from left to right. So the right when atrium will be overloaded first. When right atrium is overloaded, then what happens is this extra amount of blood will go to right ventricle, right? Then what happens? Right ventricle will be overloaded. When right ventricle is overloaded, when the ventricles are constricting, more and more blood will go to the pulmonary circulation. More and more blood will go to the pulmonary circulation. So the pulmonary valve is normal, but now it is sending extra amount of blood from the normal valve. Through the normal valve, you are sending lot of amount of blood. Now this causes a turbulent flow. This is why you get the murmur, right? This is why you get the murmur. So the reason for murmur in ASD is due to what? Increased blood flow through pulmonary valve, not due to the blood flow through this defect. That is another MCQ, right? ASD, you hear a murmur. The murmur is not due to the blood flow through this defect. The murmur is due to increased blood flow through pulmonary valve, right? Now what happens is, instead of say 100 ml, right ventricle will be always pumping 120 ml because there is leaking of blood to right side. So what happens always, right ventricle is sending a lot of blood. So pulmonary valve will be late to close. Pulmonary valve will be late to close because it has to wait until extra amount of blood also goes out. So the pulmonary valve will close later than aortic valve. That is why you get fixed splitting of second heart sound. Does that make sense? Right? So you get fixed splitting of second heart sound because the pulmonary valve will be always closing later than aortic. That is why in ASD you get fixed splitting of second heart sound. So I think you understood now why ASD doesn't cause cyanosis, we know. What is the reason for murmur, we know. And why do they have fixed splitting of second heart sound, also we understood. Right. And then the treatment is, as long as the patient is asymptomatic, we can close this with a device, right? Transcatheteral device closure is the option, right? So this is what we do. Now, the characteristic findings in most patients with ASD, there is wide splitting or fixed splitting of second heart sound, and there is ejection systolic murmur, right? Where the middle and upper sternal border is the best place to look for this murmur, right? And then if the VSD is very big, rarely it can cause heart failure, but most of the times these children are asymptomatic. They might have subtle failure to thrive, not a lot, right? Subtle failure to thrive. Transcatheteral device closure or surgical closure is advised for all symptomatic patients, right? Symptomatic patients, you might do it urgently, but otherwise you might do it later. The timing for elective closure is usually after 1 year of life. after 1 year of life, you might think of closing. And generally, we tend to do this before they start schooling, that is before 5 years of age, right? So there are a lot of, yeah, and then, yes, and there are a lot of books that we can refer to when we sit for MRCPCH exam. But if you see RCPCH, what do they refer? What do they refer? They usually refer Nelson textbook of pediatrics. This is like the Bible of pediatrics. So everything that we discuss, or I discuss, are from that book, right? So this everything that are there on these slides, credible, right? Because they are from Nelson, right? And then why answer A is wrong, right? Why answer is A is wrong? Because why? The surgery should not be done urgently because the child is asymptomatic. And reassuring is inadequate because ASD needs closure, right? And answer E is wrong. Valvoplasty. Valvoplasty is generally done for children with stenosed valves, right? Stenosed valves. And you can assess feeding. That is not wrong, but that is not the best service that we can give to this mother and child, right? Therefore, the answer is transcatheter ASD closure, right? Okay. Next question.
Sir, a small doubt.
Yeah.
Sir, for this child, we are going to do the closure, but
Mhm.
as the baby's reduce weight, until it gain weight, don't we have to wait, or the device closure will be done even before gaining the proper weight? Is asking.
Usually, it all depends on how symptomatic the child is, but generally, we wait until the child's weight is more than 10 kilos, right? That is the general agreement. If the child is symptomatic, if you think that child might die if you don't do surgery in next 1 week time or so, in that case you might do the surgery immediately, right? But however, if the child is not very symptomatic, if you think that you can wait for some time, in that case what we generally do is we refer these children to the pediatric nutritionist, and then they will give the best diet plan. And sometimes these children might need nasogastric feeding. After doing those, we try to optimize their weight at least more than 10 kilos, and then we go for the surgery. Having said that, having said that, in the UK and even in most of the other countries, cardiothoracic surgeons are skilled enough to do surgeries even on 1 kilo, 2 kilo children, 2 kilo babies, right? So that all depends on how symptomatic the child is, right? As long as he is not symptomatic, we wait at least until 1 year of age. If the child is mildly symptomatic, if you think that you can wait until the weight is better, you might wait until their body weight is more than 10 kilos.
Thank you, sir. Thank you, sir.
Right. Next question, please. Right. A 5 months old baby presents with poor feeding and dyspnea. His growth was poor and he was admitted to ward multiple times due to respiratory tract infections within last 5 months. Upon examination, a soft pansystolic murmur was heard just over the lower left sternal border. He is not cyanosed, but duskiness was noted while crying. What is the most likely diagnosis? Right. Okay. Yes. So just keep your answer written somewhere and see whether that answer is correct. Right. Okay. Right. So here, 5 months old, poor feeding and dyspnea. So what does this mean? Not like the previous child that we were discussing about. This child or this baby is symptomatic, isn't it? So this baby is symptomatic. Growth was poor, and he has been in the ward, like in and out for respiratory tract infection. So the examination, soft pansystolic murmur, right? Soft pansystolic murmur over left lower sternal edge. He was not cyanosed. Slight duskiness is there. Right. Okay. Now this is a bit tricky, right? So they don't 100% say that cyanosis is not there. But the question is very clear that no cyanosis, but there's a bit of confusion. What does this duskiness mean? Right? Duskiness mean. Anyway, so if you put everything together, right? If you put everything together, what could be the likely answer? Right? What could be the likely answer? Now the question is it a cyanotic heart disease or acyanotic heart disease? Very likely it is an acyanotic heart disease because it clearly says he was not cyanosed. He was not cyanosed, right? So very likely it is an acyanotic heart disease. But someone wanted to argue, no, there is this duskiness is there. So this could be cyanotic as well. Okay, fair enough. But if you think that it is a cyanotic heart disease, what is the option? It could be tetralogy of Fallot. Tetralogy of Fallot. That is only cyanotic heart disease here, right? Now, tetralogy of Fallot, we will discuss little later today. Tetralogy of Fallot, the murmur that they get is an ejection systolic murmur at pulmonary area, right? It's an ejection systolic murmur at pulmonary area. Here, the murmur is not ejection systolic, right? It's a pansystolic murmur. So pansystolic murmur and tetralogy of Fallot generally do not go together, right? Generally do not go together. So it's unlikely that tetralogy of Fallot. Plus, if it was tetralogy of Fallot, if examiner wanted us to choose that transfer, he would not be literary. He would clearly say the child is cyanosed. Right here, it's not saying that cyanosis is there. So tetralogy of Fallot is unlikely. Then what could be the answer? Is it a large ASD? We have already discussed about ASDs in our first question. ASD, the typical auscultatory features are ejection systolic murmur at pulmonary area, isn't it? Ejection systolic murmur at pulmonary area with fixed splitting of second heart sound, right? Here it is a pansystolic murmur at lower left sternal edge. So lower left is not pulmonary and it is not ejection systolic either. Therefore, this is very unlikely to be an ASD. So that is out, right? That is out. Then the next possibility, could that be a large VSD? You know, VSD, the murmur is best heard at left lower sternal edge. So this could be a VSD, right? Then could that be a large VSD? Yes, if the defect is big, the murmur will be soft. You know, that is simple Bernoulli's law, isn't it? If you have a bigger defect, the turbulence through that will be less. So you might not hear, the things will not be much noisy, right? So if the VSD is big, the murmur will be soft, right? Murmur will be soft. So this is a soft pansystolic murmur at left lower sternal area. Could that be a VSD? Yes, this could be a VSD. So that is possible. Now the question is, can VSD cause this duskiness? We will go to that point a little later. Could that be mitral regurgitation? No, mitral regurgitation, right? What happens is during systole, blood will leak through mitral valve. During systole, blood will leak through mitral valve from left ventricle to left atrium. left ventricle to left atrium, blood will leak through mitral valve. So that causes a pansystolic murmur. However, we know from our undergraduate knowledge, in mitral regurgitation, murmur is best heard at the apex, right? Not at the left lower sternal edge. So it is unlikely. Then is it isolated heart failure? Isolated heart failure without any defect? No. Isolated heart failures generally do not cause murmurs, right? So that is unlikely. So the best answer out of these 5 is a large VSD. So very likely it's a large VSD. Now, why do they cause heart failure? Now we see now VSD, the defect is here. So the blood will go from left ventricle to right ventricle. So what will happen? Right ventricle will be overloaded, isn't it? Right ventricle will be overloaded. When right ventricle is overloaded, more and more blood will go to the pulmonary system, right? Pulmonary system will be flooded with blood. Pulmonary system will be flooded with blood. The lungs will be then wet. It is like drowning, right? Instead of air, you will have a lot of water, lot of fluid in the lungs. That might cause more and more difficulty in breathing and dyspnea. And then what will happen? This increased amount of blood from the lungs need to come back, right? Need to come back. And this will cause, again, more and more congestion in the left side as well, right? So this is why the children with VSD will have features of heart failure. That will be more so if the child has a large VSD. Large VSDs are generally symptomatic. They will present with features of heart failure, right? Features of heart failure. This is the very reason why we need to close them early. There are several other complications that VSDs might cause if you don't close them timely, right? So the other problem of large VSD is, right, with large VSD is, now when you are sending a lot of blood, now you see, blood will go from left ventricle to right ventricle. So the right ventricle will be overloaded. Then what will happen? The pulmonary circulation will be overloaded, right? Pulmonary circulation will be overloaded. Pulmonary vessels are meant to have flooding of blood. When you see the pulmonary blood flow is getting more and more, right? As a protective mechanism, pulmonary blood vessels will go into some structural changes. Structural changes. Now, the pulmonary blood vessels say, now look, right? We are getting a lot of blood that we are not supposed to have. If this goes on happening, our vessels are going to damage. Before that happens, we need to take our own protection. So what do? The pulmonary vessels will go into some structural changes. This will cause pulmonary hypertension. This will cause pulmonary hypertension. Therefore, if you have a large untreated VSD, right, with time, what will happen? More and more blood will go to the lungs. Then pulmonary vessels will undergo some structural changes that will cause pulmonary hypertension, right? This will lead to pulmonary hypertension, right? So this is some extra point anyway. So VSD can cause heart failure, pulmonary hypertension as well, right? Okay, so why do you think that this is a VSD for our question? Because it causes a pansystolic murmur at left lower sternal edge. Plus, if it's a large VSD, the murmur will be soft, right? Murmur will be soft. And large VSD will cause flooding of blood into the lungs. That will cause heart failure. That is why these children will have poor feeding and dyspnea as well. Right. And VSD, obviously, the blood will be going from left to right. Therefore, it is an acyanotic heart disease, right? It's an acyanotic heart disease, right? So why do we say that it is VSD? Because it's an acyanotic heart disease. Soft murmur indicates large defect, and it's a pansystolic murmur. MR and VSD both can cause pansystolic. However, MR is heard in mitral area, not left lower sternal edge, right? And this is what standard textbooks say about large VSDs. Large VSDs with excessive pulmonary blood flow will lead to pulmonary hypertension, and then this also can cause congestive heart failure. Because of that, there will be dyspnea and feeding difficulty, poor growth, and profuse perspiration or sweating, right? And then because the pulmonary vessels are, pulmonary circulation is wet, this wet medium is a good recipe for infections to develop. That is why these children present with recurrent chest infection. Right? Recurrent chest infections are common with cardiac problems, which cause more and more blood going to pulmonary system. And this is what Nelson says. Cyanosis is usually absent, but duskiness sometimes noted during infections or crying. Right? So duskiness is not something that you do not see with VSD, you see them, right? So answer A is out because tetralogy of Fallot is a cyanotic heart disease. Answer B is wrong because ASD causes an ejection systolic murmur, not a pansystolic murmur, right? And answer E is wrong because this can't be an isolated heart failure, because if that is the case, you would not get a murmur, right? You would not get a murmur, right? So the idea of discussing these questions is not just to say answer is this, but to get a broad idea about the pathophysiology, physiology, and then complications, and how to understand the clinical features associated with these conditions, not just to memorize. Right. Okay, so that's about this question. Right. Next one. A healthy 3-year-old boy was found to have a hernia and was referred for surgery. He was noted to have a systolic murmur but no other abnormality. Diagnosis of a small VSD was confirmed by echocardiography. His mother asks the general practitioner for advice. What is the most useful advice for the mother? Right. Yes. Anyone who would like to answer? Deshanjali, any? Yeah. Yeah. Kevin, any idea?
So the boy will have to have routine surgery for the hernia, then the surgical correction of the VSD.
Okay, surgical correction of the VSD. Okay, so that is something that you think. Okay. Any other answer? Loshika?
Sir, I think answer would be B, because you have to correct the heart problem before any surgery. Like,
Okay, right. Anyone else? Now I'm telling some random name. If you don't know the answer, you can just stay silent. You don't have to stress yourself. Right? Yeah. But if you know, if you feel like giving the answer, you can give the answer. It doesn't necessarily have to be correct, right? Nobody's there to bully you, anything like that. It's a professional discussion. Yes, anyone? Any other different thoughts? Yeah, I have got some other answers personally to chat. So some students think that the answer is D.
E,
Some
sir.
students E, the fifth one, is it? Right. Okay. Now here, the question is very clear. There is nothing to find out. Like the question itself says that echocardiogram has found a small ventricular septal defect. So that is very clear, right? We know that the diagnosis is small ventricular septal defect, right? So now mother is asking advice from general practitioner, right? So now the examiner is asking, right, us to give the best advice. So what does this mean? Whether the examiner is testing whether we know the natural history of a small VSD and what the complications of small VSDs are, right? So that is the piece of knowledge that they test, right? So when you do a question, please remember, please try to ask from ourselves. Now, by putting this question to MRCPCH paper, what probably is the examiner's agenda? What does he really want to test in me? Right? So, what is tested here? He's checking whether we know the natural history of a small VSD and its complications. Right. Now, because now this is a small VSD. Now, as long as the VSD or the heart problem is suitable enough for child to undergo the surgery, like anesthesia point of view, if you think that this child is fit for anesthesia, heart problem should not delay the surgery. Was that understood? Right? Now, the small VSDs generally are asymptomatic. Therefore, you don't have to wait until you do the heart surgery. Right? Small VSDs are asymptomatic. Therefore, these children can undergo surgery. Right. So that is the first piece of knowledge that they test in us. Was that understood? Right. The next question is, right, when you see a child with a heart problem and undergoing procedures, what comes to our mind? Infective endocarditis, isn't it? Infective endocarditis. Now the question is, do you have to give infective endocarditis prophylaxis to these children? In the UK, NICE guidelines do not recommend this, right? Do not recommend this. Therefore, they do not have to have prophylactic antibiotics. The proper dental hygiene is encouraged. However, NICE does not recommend prophylactic antibiotics to prevent infective endocarditis in susceptible children, right? So anesthetist will advise about antibiotic cover. No, he might advise that antibiotics are not needed. Right? That should be the advice. But otherwise, there won't be advice. This is the antibiotic that you should give or anything. So answer A is wrong in that on that basis. Answer E is also wrong. The GP will prescribe oral penicillin. No, we don't have to. Right? Some countries still practice giving antibiotic prophylaxis depending on their prevalence of various diseases, infections. However, UK does not recommend it anymore, right? So that is out, right? Now, the boy needs surgical closure of VSD before hernia repair. No, because this small VSD should not be a reason, disturbance to go ahead with this minor or like fairly uncomplicated surgery. No, that is out. Boy will have routine surgery for hernia, then he will need surgical correction of VSD. Right. So that is one option. The other one, boy will have routine surgery for hernia and VSD will close spontaneously. You see, the first part of answer C and D both are the same. Right? Boy will undergo routine hernia surgery. That part is the same. Now, the next question is, what is going to happen to this small VSD? Will it close spontaneously or will that need a surgery later? So the natural history of small VSD is tested here. We need to know most of the small VSDs will close naturally, right? They will close naturally. So we need to confidently tell the mother that child can undergo surgery, no problem. He would not need any antibiotics. VSD is fairly small. What we generally see is these VSDs will close spontaneously. So 90% of time, this will not need a surgery. However, you will need to follow up. The child should be followed up by a cardiologist, right? So that is what we have to tell. So the best answer should be D, right? A, B, C, D, right? So that's the answer about, yeah, the VSD and their surgical corrections and complications, right? Because different students had different thoughts. Anyone having any questions to clarify or ask? Or are we happy with this? Yeah, anyway, that's the answer, right? That's the answer. So we need to know a few things, right? This question might not repeat in your exam. However, the concepts will be repeated. What are the concepts? What happened to small VSDs, right? And do we recommend endocarditis prophylaxis in United Kingdom, right? What is the impact of like minor congenital heart diseases on routine surgeries, right? So those are the few things that we have to know. As long as we understood that, right? Next question. A 12-year-old well-looking boy was found to have a radiofemoral delay on physical examination. Upon blood pressure measurement, his blood pressure of legs was lower than that of arms. The characteristic chest X-ray finding is fairly easy question. Yes. Does anyone want to answer? Yeah. Asmina, what are your thoughts? Yeah, if you don't want to answer, just pretend that you did not hear, right? So that's fine. I'm just telling random names. You don't have to answer. Right. Yes. So what is this? Now, sorry. Now, radiofemoral delay, right? On physical examination. Now, what does this mean? What is the meaning of radiofemoral delay? If you go by the English meaning, radiofemoral delay is you feel radial pulse first, then you feel femoral. Yeah, that is correct. But radiofemoral delay also means that you feel radial and femoral pulse. Sometimes you might feel that at the same time, but femoral pulses are weak. That again is radiofemoral delay, right? If femoral pulses are weak, that again can be radiofemoral delay. So here the child is having radiofemoral delay, which means there is some problem with blood coming to the femoral area. And then upper limb blood pressure is high, or lower limb blood pressure is low. Probably there is some reason why you don't get enough blood flow to the lower limbs. If you put them together, what is the most likely diagnosis? Again, undergraduate stuff, there is some obstruction towards the aortic part which supplies the lower extremity. So this commonly happens in coarctation of the aorta, isn't it? Coarctation of the aorta. So by the time coarctation happens, it has already given its branches to upper limbs. So upper limb blood supply is intact, whereas lower limbs are going to suffer. This is what happens in coarctation of the aorta, right? But the question is not that. What kind of chest X-ray appearance are you going to see is the question, right? So that is the question. Now, if you look at coarctation of aorta, now this is aorta, and this is ascending aorta, and here you see the narrowing, right? Here you see the narrowing. Now, when you see this narrowing, right, if I'm to be little dramatic, right, so this is how it goes, isn't it? So, sorry. Right. So if you aorta, if you go like this, and then at this point, it starts, right, having bit of a bending, right, bit of a bending. So if you look at this in a chest X-ray, you see something like figure of three appearance, right? This is called figure of three appearance, right? Figure of three appearance. Now, what else would happen? Now, when you have coarctation of the aorta, right? Coarctation of the aorta, you don't get enough blood to the descending aorta, right? You don't get enough blood to the descending aorta. So descending aorta is going to suffer. Therefore, descending aorta or the lower extremities will start to get from this ascending aorta through anastomotic pathways, right? There may be anastomotic blood vessels coming to support the lower limb blood flow, right? Through different blood vessels like internal thoracic arteries and all. Now, those arteries will start sending blood towards descending aorta area. Now, for these anastomotic blood vessels to form, right, intercostal arteries will contribute, right? Intercostal arteries will contribute. When intercostal arteries are involved in anastomotic pathways, what happens? Intercostal arteries will start enlarging. When intercostal arteries enlarge, right? When intercostal arteries enlarge, this causes erosion of the ribs. Erosion of the ribs, what we call rib notching, right? Rib notching. So if you look at the chest X-ray in a child with coarctation of aorta, you might see two things: figure of three appearance and rib notching, right? Figure of three appearance and rib notching. So those are the two things that you are going to see. Now, for you to see those, it takes years, right? It takes years. If I say that the child is 2 years, right? Child is 2 years instead of 12 years, then the X-ray appearance might be otherwise normal. Because for you to get rib notching, it takes a lot of time, right? So if the examiner said that this child is 1 year of age, what do you see in chest X-ray? The answer could be chest X-ray is normal. Chest X-ray is normal. Whereas 12 years old child, we expect this child to have some changes by now. So what do you see? There will be notching of inferior border of the ribs. Now, why not? The other answers are correct. Now, we'll go to that point a little later. Now, in coarctation of aorta, what happens? There is constriction of aorta to various degrees. It may occur in different points, but before the bifurcation, right? And then the male to female ratio is more in males. It's more in males. And there is a discrepancy in blood pressure in upper limbs and lower limbs. There's radiofemoral delay. The typical syndrome associated with coarctation of aorta is Turner syndrome, right? Turner syndrome. Child with Turner syndrome presented with headache, then what do you have to check? Could that be coarctation of aorta? Why do they get headache? Because of coarctation, they can have high blood pressure. That can lead to headache. So what do you want to check? If this child, right? If this child comes in MRCPCH clinical station and CVS, right? CVS, what do you want to check? There are a few things. Full examination of CVS is needed, right? However, when it comes to CVS, what are the few things that you need to check? Examination of the blood pressure in upper limbs and lower limbs is a must. If you do not do that, or if you do not offer that, it's a clear fail. It's a clear fail. There's no way how we can pass coarctation of aorta without offering for blood pressure checkup. Then we need to check if the child is having radiofemoral delay, and whether the femoral pulses are normal. And then coarctation of aorta can also have a murmur at aortic area. Ejection systolic murmur is possible, which radiates to the back, or interscapular area. Right. So those are the few things that we might have to check if this child appears in CVS station in MRCPCH clinicals. Right. So that's about coarctation of aorta. Right. And then several other X-ray appearances are given as other possible answers. Why are they wrong? This can't be snowman appearance, right? Snowman appearance is a typical chest X-ray finding that we get in TAPVD, right? What is TAPVD? Total anomalous pulmonary venous drainage. Right? In total anomalous pulmonary venous drainage, we get a typical X-ray finding, X-ray appearance that is called snowman appearance, right? Snowman appearance, right? What is the other way how this is described, right? If you look at this, somebody can see number 8 here, isn't it? It is also called figure of 8 appearance, right? Figure of 8 appearance. It either can be described as figure of 8 appearance or snowman appearance, whatever it is, it's TAPVD, right? Not coarctation of aorta. And then boot-shaped heart is classic in tetralogy of Fallot, right? So this is not tetralogy of Fallot, so that is also out. And then you get something called box-shaped heart. Box-shaped heart in Epstein anomaly, right? Epstein anomaly causes a box-like heart on chest X-ray, right? So these pictures might be given in AKP or Theory and Science or whatever the paper, and they might ask, okay, this X-ray appearance was seen in the child. What is the likely diagnosis? Remember, they might give some pictures, right? They might give some pictures. So it's a good idea to be familiar to these typical X-ray findings in congenital heart problems. And then you get something called egg on the side appearance, right? Egg on the side appearance. So this egg on the side appearance occurs in a condition called TGA, right? TGA, right? TGA. How I remember that is egg has got letter G, TGA also has got letter G. So that's how I remember. You can remember it whatever the way you want. However, TGA causes egg on the side appearance. If we are to summarize the typical X-ray features of congenital heart diseases, TGA, egg on the side. Epstein anomaly, box-shaped heart. Tetralogy of Fallot, boot-shaped heart. TAPVD, snowman appearance or figure of 8 appearance. And coarctation of aorta, rib notching, right? Rib notching, right? So even if you went this answer wrong, as long as you understood few typical X-ray features of congenital heart diseases, that will be invaluable for our exam. Right, okay, next question. A 5-year-old boy has normal first and second heart sounds with a loud pansystolic murmur at left lower sternal edge, but no thrills. He has no cardiac symptoms. What is the most likely diagnosis? This is very easy. Five-year-old, first and second heart sounds are normal. Loud pansystolic murmur at left lower sternal edge. No thrills. Yes. Yes, so easy. Anyone likes to answer? Yes. Right. Okay. Now, when you see a pansystolic murmur, right? Pansystolic murmur for our exam purposes, right? There are few reasons for a child to have pansystolic murmur for MRCPCH purposes, right? 3 common causes of pansystolic murmur are VSD, right? Tricuspid regurgitation and mitral regurgitation, right? Out of 3, mitral regurgitation or mitral valve prolapse. Mitral regurgitation or mitral valve prolapse usually cause a pansystolic murmur at the apex. So that is out, right? That is out. Then what is likely? This is likely to be a ventricular septal defect. The other possibility is this could be a tricuspid regurgitation, but that option is not there in the list, right? So what could this be? This could be a ventricular septal defect. What kind of VSD is this? If the examiner gave 2 answers, large VSD and small VSD, what are you going to choose? Large or small? Large VSD or small VSD? Yes, in this question. Yes, yes, this is small VSD because why? The murmur is loud, right? Murmur is loud. Therefore, the defect should be small, right? It's a small defect. That is why you get a loud loud murmur. All right. So this can't be coarctation of aorta. Coarctation of aorta, you might hear a murmur at aortic area, not left lower sternal edge. That is out. Could that be a functional murmur? Could that be a functional murmur? So you see normal first heart sound and second heart sound. But the child looks otherwise well. Therefore, could that be functional? No. Why not? Functional murmurs are ejection systolic in nature. Right? Functional murmurs are ejection systolic in nature. They are not pansystolic. Right? They are not pansystolic. If you get a separate question regarding functional murmurs, right? What are the features of a functional murmur? You can just write down features of functional murmurs. Functional murmurs are always systolic, right? They are always systolic, and they are best heard at pulmonary area, right? Best heard at pulmonary area. What is the type of murmur? They are ejection systolic. They are never diastolic, right? They are never diastolic. Usually, the heart is otherwise normal. What does this mean? First and second heart sound is normal. No features of heart failure, no cyanosis, nothing. Right. And functional murmurs usually do not radiate to anywhere. Right. Functional murmurs would not radiate to the neck or anywhere. And then functional murmurs might appear or disappear depending on child's different posturing. Right. When you bend the neck, sometimes murmur might disappear. Again, it might appear when the neck is extended, so that kind of things. You don't get those in pathological murmurs. Whatever the position, you will hear the murmur in pathological. Right. What are the causes of functional murmurs? Functional murmurs are heard when you have hyperdynamic circulation, such as fever. Fever can cause functional murmur. Anemia, thyrotoxicosis, right? They all can cause functional murmur. Right. What is the management of functional murmurs? Reassure the patient, right? Reassure the patient. Once the acute condition is settled, say fever settled, anemia treated, right? You reassess to see if the murmur is still there. Likely it will not be there if this was functional, right? If this was functional. So this is not functional because functional murmurs are not pansystolic, right? Mitral valve prolapse we excluded. And then could that be patent ductus arteriosus? No. Patent ductus arteriosus causes a continuous murmur, what we commonly know as machinery murmur. They are usually heard below the left clavicle, below the left clavicle, right? So this is not the place where you hear PDA murmur. Therefore, the best answer is that this is a VSD, right? VSD is the answer. Right, next question. A 3-year-old child with trisomy 21 who was diagnosed as having a cardiac pathology, presented with fatigue, dyspnea, and generalized edema. He was cynosed. Physical examination revealed a right ventricular heave with narrow and splitting of second heart sound with loud pulmonary component. There was a palpable thrill over the pulmonary area. Chest X-ray showed cardiomegaly and increased pulmonary vasculature. What is the most likely diagnosis of this patient? Again, extremely easy. Yes. Right. So this question is fairly easy, right? So we know trisomy 21 or Down syndrome is very well known to cause heart problems, right? What is the commonest heart problem that they get? AVSD, atrioventricular septal defects. They also can have VSD, right? Now this child is presenting with cyanosis, right? So the child has gone into cyanosis by now, and he is fatigued and dyspneic, right? Fatigue and dyspneic. This could be heart failure, or this also could be due to pulmonary hypertension. There is right ventricular heave. What does this mean? Right ventricular heave means the right ventricle is prominent, right? If you keep your fingers at sternal border, you will feel that your fingers are lifted up. Fingers are lifted up. This is what happens in parasternal heaves or right ventricular heaves. Now, when you have right ventricular heave, that generally indicates that the right ventricle is hypertrophied. Right ventricle is hypertrophied, and there is a palpable thrill over pulmonary area. So there probably is a murmur going on in pulmonary area. Chest X-ray shows cardiomegaly and increased pulmonary vasculature. So there is something to do with the heart and pulmonary vessels, right? Heart and pulmonary vessels, and the child is cyanosed, right? Child is cyanosed, right? Now, what are the possibilities, right? Could that be VSD? Simply no, because VSD doesn't cause cyanosis. Plain and simple VSD should not be the answer because that doesn't cause cyanosis. That's out. That's out. Then could that be ASD? Again, no. Plain and simple, uncomplicated ASD doesn't cause cyanosis. That is also not the answer. Right. Then could that be PDA? No. PDA causes a continuous murmur, and PDA per se should not cause cyanosis. So the two possible answers, if you consider cyanosis as an anchoring term, the possible two answers are either it is Eisenmenger syndrome or tetralogy of Fallot, right? Tetralogy of Fallot. Now, out of two, what is more likely? We have not discussed tetralogy of Fallot yet. However, one of the major components of tetralogy of Fallot is infundibular pulmonary stenosis. Infundibular pulmonary stenosis. Tetralogy of Fallot is a condition where the pulmonary blood flow is limited. Pulmonary blood flow is naturally limited. Therefore, you do not get increased pulmonary vasculature, right? Pulmonary vasculature is not increased. Also, generally in heterogeneous fellow, you don't get cardiomegaly in general, but you will have right ventricular prominence with boot-shaped heart, right? Boot-shaped heart. So heterogeneous fellow is unlikely. Now, could this be Eisenmenger? Yes. Yes. So what is Eisenmenger? Eisenmenger is a condition where you get pulmonary hypertension developed due to some primary pathology. When you have pulmonary hypertension, right? Pulmonary hypertension, what happens? Sending blood to the lungs is difficult, right? This is simple, isn't it? When you have high pressure in the pulmonary area, so you can't send blood easily. Therefore, what is going to happen? So what is going to suffer? Right ventricle is going to suffer because it's responsibility to send blood to the pulmonary. Now the pulmonary is demanding, no, don't send via high pressure people. Now the right ventricle is going to suffer. When right ventricle can't send blood to the high pressurized pulmonary area, right ventricle is going to hypertrophy. Right ventricle is going to hypertrophy. That is why you get right ventricular or parasternal heave. The other classic feature of pulmonary hypertension is loud pulmonary second heart sound, which is very prominent in this question, right? Which is very prominent in this question. If you see pulmonary heart sound prominent in MRCPCH questions, that is pulmonary hypertension. If you start to hear those in your clinical exam, again, you are dealing with a child with pulmonary hypertension, right? So pulmonary hypertension could occur simply due to VSD. So you have VSD, you can remember, we can remember VSD very well. VSD, there is left to right shunt. So the right ventricle will be overloaded. When the right ventricle is overloaded, more and more blood will go to the lungs. That can cause pulmonary hypertension. Later, this can cause right ventricular hypertrophy as well. Right? So this is what happens in Eisenmenger syndrome. Therefore, most likely diagnosis here is Eisenmenger. Why do I say that it is Eisenmenger? Eisenmenger causes pulmonary hypertension. That is why you get loud second heart sound. Because of pulmonary hypertension, you get right ventricular hypertrophy. That is why you get heaves. By the time you get pulmonary hypertension developed, right ventricular pressure will be very high. When you have more and more pressure developing in the right side, at one point, blood will start to go from right to left ventricle, right to left ventricle. That is when you start to have mixing of dirty blood into good chambers. Mixing of dirty blood into good chambers, then the child will start to be sinused, right? There will be cyanosis. The reversal of the shunt, right, with associated increased pulmonary pressure evidenced by loud second heart sound. So this is Eisenmenger. The child has gone to this stage, likely he would need heart-lung transplantation. So our idea as primary physicians is to make sure that child doesn't go into this stage. Before this happens, it's our responsibility to surgically close the VSD or whatever the primary lesion which causes pulmonary hypertension. Right. And just to compare, what kind of second heart sound do we get in tetralogy of Fallot? Tetralogy of Fallot, pulmonary blood flow is naturally limited due to infundibular pulmonary stenosis. Therefore, in TOF, remember this very well, in TOF, second heart sound is soft. In TOF, second heart sound is soft, whereas here, second heart sound is loud. Therefore, the best possible answer is Eisenmenger syndrome, right? Answer is Eisenmenger syndrome. Few things about Eisenmenger. This might come as a different MCQ. They might not be symptomatic until their second or third decade of life, right? And when they start to be symptomatic, there will be cyanosis, dyspnea, and then when you have right ventricular enlargement, right? When you have right ventricular enlargement, what happens, right? When you have right ventricular enlargement, like this, Now the right ventricle is having high pressure due to some reason. So the some reason is pulmonary hypertension. When you have increased pressure in the right ventricle, inferior vena cava will find it difficult to send blood upwards. So upward blood flow through inferior vena cava will be limited because the right ventricle is already having high pressure. That will cause edema. That will cause edema. And because you are not getting enough oxygenation, the child might feel fatigue as well. At some point, they might get arrhythmia, heart failure, chest pain, syncope, right? All these are possible. If the pulmonary pressure is very high, sometimes this can cause rupture of pulmonary vessels that can cause hemoptysis. Right? Physical examination, there will be right ventricular heave and splitting of second heart sound with loud pulmonary component. Right? The pulmonary arterial pulsation could be palpable as well. Right. So this is same thing, Eisenmenger. There will be, when by the time you get Eisenmenger, fully developed, full-blown Eisenmenger, right ventricular pressure might exceed that of left ventricular pressure. That is when you get blood shunting from right to left, dirty to good, dirty to good. That is when you get cyanosis, right? That is when you get cyanosis, right? Okay, so that's about Eisenmenger syndrome, right? So bit of explanation regarding why other answers are wrong. Patient is cyanosed, therefore ASD, VSD, and PDA are not possible. ASD, VSD, PDA are not possible, right? In tetrajaw fellow, you will hear a pulmonary stenosis murmur, ejection systolic, and usually they have soft second heart sound, not loud, right? Not loud. PDA, the murmur is continuous, right? Not this kind of murmur, right? Okay, and children with trisomy 21, they have associated atrioventricular septal defects, which can be the primary cause to develop Eisenmenger later, right? Okay, so that is why Eisenmenger is the answer, right? So this is, again, a picture of a child with Eisenmenger syndrome, chest x-ray, and this is the typical appearance of children with Down syndrome. This is too easy to diagnose. Sometimes you might get a child with Down syndrome in clinical station, miscellaneous case, right? What are the common stations where you might see a Down syndrome child appearing? Yeah, Down syndrome could appear in CVS station, clinical, or he might be there in development assessment station, right? Development assessment. They might ask, okay, how to do this development assessment in a child with Down syndrome, like that, right? And then Down syndrome can come in theory paper, like here in cardiology. Down syndrome children can have neurological problems, hypotonia and all. So this could be neurology. Down syndrome children can have multiple problems with gastrointestinal system, like duodenal atresia, Hirschsprung. So it could be that kind of patient as well. And sometimes behavioral problems, they are more common to get: autism, developmental problems, behavioral problems, cognitive impairment, learning disability, you name. They could be everywhere in MRCPCH exam, right? So knowing about Down syndrome, A to Z, top to bottom, will be life-saving, right? Next question. Right. Let's give a try. A neonate presented with tachypnea, diminished femoral pulse, brachial pulses are present, pulse rate 170, upper limb pressure is more than lower limb. What is the immediate management? Immediate management. Right. Now, this question should be easy. Tachypnic child, baby, diminished femoral, and then brachial pulses are there. Upper limb blood pressure is more than lower limb. As we already discussed, this is likely to be coarctation of aorta, right? Newborn babies can present with coarctation of aorta. So what the management is going to be. Now, coarctation of aorta in the UK is generally diagnosed antenatally. This is not a surprise, right? Babies with coarctation of aorta will be antenatally diagnosed most of the times. When that is the case, they usually are delivered in tertiary centers with cardiac surgery facilities, or once they are born, they will be transferred urgently or early to a tertiary cardiac center, right? So there will be something called fetal case notes, right, which will be generated before the baby is born. Those fetal case notes are generally prepared by the gynecologist, the neonatologist, and other relevant subspecialists. Antenatally, if the mother was found to know that the baby is having coarctation of aorta, the neonatologist will be called before the baby is delivered, like few months before at least, and then they will make a plan, right? Then they will give clear instructions after the baby is born. If the baby is like this, do this. If the baby is like this, do that, right? So like that, all the instructions will be given. If things go in a way that we did not expect, if you say you planned baby to be transferred 3 days after birth, and then baby started to be symptomatic, now you think that the baby should be transferred immediately, and then helicopter services available in most of the areas in the UK. Helipads are available in most of the hospitals. You can just send children to London, Manchester, you name, Southampton, within a matter of 1 hour, right? Within a matter of 1 hour, and then they will do surgery if they think that should be corrected immediately. So that's what happens. Now, this baby was found to be having high blood pressure in upper limbs, lower limb blood pressure is low. So this is coarctation of aorta, right? Now, what should you do? Now, in coarctation of aorta, what happens? The blood flow to the lower limbs will be reduced, obviously, right? Now, this is what is happening, right? Blood flow to the lower limbs will be reduced. Now, what are we going to do? If you want to maintain some amount of blood flow to the lower extremities, right? How can you achieve that, right? How can you achieve that? Now, this is where the ductus arteriosus is going to be life-saving, right? So there is this ductus arteriosus, right? Ductus arteriosus is there. If the blood flow to the lower extremities is very low, right, you might support the baby or release the pressure a little at least, right? Because there is a lot of pressure developing because nothing is pumping beyond this point, right? Nothing is pumping beyond this point. So if you want to release some pressure and send some blood to the lower limbs, what you can do is you can open this ductus arteriosus if it has already closed. If it has already closed or closing, right? So coarctation of aorta management, immediate postnatal period is opening the ductus or keeping the ductus patent. How do you do that? By giving prostaglandin, right? So prostaglandin is something that we give as an infusion. Prostaglandin can cause a lot of side effects like apnea. So we have to be ready to intubate, right? These babies. Now, not like in most of the hospitals where the hospital staff, hospital doctors, nurses will bring these babies to tertiary centers, but that is not the case in the UK. There is neonatal retrieval services available, right? If you think that the baby should be transferred from one hospital to the other hospital, you will call neonatal transport team. So they will come, and then they can transfer the baby depending on the urgency, right? They can be sent in a helicopter or ambulance, you name, whatever, while on prostaglandin drip, right? Prostaglandin can cause apnea, respiratory problems. In that case, baby might need intubation as well. So this is what happens, right? This is what happens. You might simply get a question, you transfer the baby to London. No, we don't do that, right? You accompany the baby to London. No, that is not the way what is happening in the UK. Neonatal transport team will come. They will take the baby from one hospital to the other hospital with optimal care. That is their job, right? That is their job. So that is what they do, right? So nasal prong oxygen is not going to be helpful. So you need to improve, or you need to relieve this obstruction or increase some blood flow going to the lower extremities by keeping the ductus open. So what you do is giving prostaglandin, right? Endotracheal intubation is not needed because the primary problem in this baby is not airway obstruction. Nasal prong oxygen is not going to be helpful. Administration of 10 ml per kg fluid bolus might cause even death, right? This baby is already having heart failure, already having high blood pressure. On top of that, if you overload the baby, he might die. He might die. So that is not something that we do, right? So prostaglandin infusion can be done and transfer to a cardiac center. Yes, you can do that. But now, if you are to choose what to do next, is that to start prostaglandin infusion or to transfer the baby to cardiac center and then start? No, the first thing is to start prostaglandin infusion, or what we call prostine, right? Prostine should be commenced immediately, and then you can transfer these babies, right? So this is what we do in management of duct dependent circulation, right? Next question. A 3-year-old boy was brought to the GP by parents following a syncopal attack while playing. On examination, child was found to be having a harsh ejection systolic murmur at the right upper sternal border, which radiates to neck. Which of following is incorrect regarding this child's condition? Right. ECG may show right ventricular hypertrophy and increased pulmonary vasculature. Balloon valvoplasty is indicated to prevent sudden death. Then this Corno procedure may be helpful. Recurrence can be identified during graded treadmill exercise. Can be associated with Williams syndrome. Yes. Right. So this question again is not difficult, right? As reading the question carefully, this is not right. Okay. Now what is this? Syncopal attack while playing. That itself is helpful. Syncopal attack while playing. While playing means what? The child is doing some sort of exercise. Now, when the child is active, we expect them to have more blood flow going to the brain, going to the other areas, and more oxygen, right? When they are exercising, when they are playing, if they do not get enough blood, that means that there is probably an outflow tract obstruction, right? Possible outflow tract obstruction. This is what happens in children with outflow tract obstructions. They find it faintish, headache while engage in some exercise. On examination, there is a harsh ejection systolic murmur at right upper sternal border. Right upper sternal border is what? Aortic area. Aortic area. So aortic ejection systolic murmur radiate into the neck is simply undergraduate stuff, right? Aortic murmurs radiate into the neck is aortic stenosis, right? Very likely there is narrowing in aortic area, right? Very likely narrowing in aortic area. So likely this is aortic stenosis. When you have severe aortic stenosis, especially, they might have syncopal episodes, especially when they are engaged in some sort of physical exercise, right? Now, if it is aortic stenosis, the problem is in the left side. Aorta is something to do with the left side, right? Aorta is something to do with the left side, right? Right. Okay. So we don't have a picture. However, this is easy to understand. So aorta is left-sided or left ventricular outflow obstruction, basically, right? Then ECG might show right ventricular hypertrophy and increased pulmonary vasculature. No, that is wrong, right? Because in aortic problems, left ventricle is the one which is going to suffer, right? Aorta will bring left ventricular blood. If the aorta is obstructed, left ventricular will get hypertrophy, not the right, not the right. So ECG showing right ventricular hypertrophy should not be an answer, right? So seemingly this is the wrong answer. It says what is the incorrect statement. We need to read the question very carefully. So this could be the incorrect answer, but we'll see whether there is a more incorrect answer. Balloon valvoplasty is indicated to prevent sudden death. Yes, balloon valvoplasty would be useful to reduce this aortic stenosis. Right? Kuno procedure can be helpful. We'll see what that is. Recurrence can be identified with graded treadmill exercise. Yes, if you start to introduce the child to have graded exercise, at one point he might start to feel syncopal. Right? Can be associated with Williams syndrome. Yes, Williams syndrome causes aortic stenosis. Right. Now, anyway, this procedure that performed for patients with aortic stenosis in association with tunnel-like subaortic obstruction, right? Anyway, this is a procedure to reduce aortic stenosis. So this procedure is done for children with aortic stenosis. So that is not a wrong statement. So the answer is A. ECG may show right ventricular hypertrophy and increased pulmonary vasculature. No, ECG might show left ventricular hypertrophy. Right? ECG might show left ventricular hypertrophy with left ventricular strain pattern. That is where you see inverted T waves in left precordial leads. Right. And this may occasionally be normal, right? But may indicate outflow tract obstruction. Balloon valvuloplasty is indicated for moderate to severe valvular aortic stenosis. And you might get recurrence of these, especially when they start to do graded treadmill exercise. Right. Now, Williams syndrome, you see, I have posted a video on Williams syndrome in our Telegram group anyway. So one of the features of Williams syndrome is they have supravalvular aortic stenosis. Right? Supravalvular aortic stenosis is something that children with Williams syndrome would get. One of the clinical features of Williams syndrome, they can have broad forehead, flat nasal bridge, mouth might be comparatively large with thin upper lip, and cheeks will be full, and they can have friendly personality. They love music, right? So those are the features of Williams syndrome. Williams syndrome also can cause hypercalcemia, hypercalciuria, that can cause deposition of calcium in the kidneys, what we call nephrocalcinosis, right? Nephrocalcinosis. So the answer for this question, ECG may show right ventricular hypertrophy is wrong. Balloon valvuloplasty is correct. Kono procedure is correct. Recurrence can be seen with treadmill exercise, correct. Can be associated with Williams syndrome is correct. Right. Right. Okay. This question. A 9-month-old baby presented with sudden onset difficulty in breathing and excessive crying for 1 day duration. On examination, he is tachypnic, a pansystolic murmur with a tender hepatomegaly. What is the immediate management to relieve symptoms, right? Shall we, if I also add that the baby's oxygen saturation is 98%, right? We can keep that in mind. Oxygen saturation is 98%. Oxygen saturation is 98%. Yeah. So what is this? Right. So sudden onset difficulty in breathing, excessive crying, tachypnic, and systolic murmur, and a tender hepatomegaly. So tender hepatomegaly and the murmur, until proven otherwise, is heart failure. Right. Tender hepatomegaly and the murmur, until proven otherwise, is heart failure. So this child is having heart failure, and there is a pansystolic murmur. This could be due to a VSD, right? This could be due to VSD. So VSD causing heart failure, and the child is currently symptomatic. What should you do to relieve symptoms? Relieve symptoms. So he might be having fluid overload at the moment. However, his saturation 98 is wonderful. So we are not bothered about saturation. So giving oxygen might not be very helpful. Right? Giving oxygen might not be helpful. In fact, sometimes giving oxygen might make the condition worse. Oxygen is a pulmonary vasodilator. When you give more and more oxygen, pulmonary vessels will further dilate. That can cause more and more congestion in pulmonary system. Unless oxygen is really needed, giving oxygen for a baby with heart failure might not be very advantageous. Right? So giving oxygen might not be the answer. So to reduce heart failure, what do you do? The basic things that we have learned in medical school will be still valid. Keeping the baby propped up position, restricting fluids, right? We might not give unnecessary fluids. You might cut down fluids to 2/3 or say 3/4 of maintenance, whatever it is. And we might not make the baby to be more and more tired. Sucking milk might be tiring. So in that case, you might put a nasogastric tube and give fluids, or you might put a cannula and give IV fluid rather than making the baby too tired by sucking milk from the bottle or breast. Right? So that is something that we would do. Now, administering normal saline bolus might be counterproductive. That might make the condition worse. And then administering IV furosemide will be very helpful. So you might remove extra amount of water as diuresis. That might make the lungs relatively dry. So that might make the baby less distressed, less tachypnic. So to reduce symptoms, this would be the best thing to do. Digoxin might not be immediately beneficial in most of the cardiac heart failures compared to furosemide. So the best answer should be giving furosemide. Right? So heart failure management is something that we need to know. Right. Right. Okay. And children with heart failure, you will see more and more blood going to the lungs. The typical X-ray appearance is that they will have plethoric lung fields, right? They will have plethoric lung fields, right? So that comes to the end of acyanotic heart diseases and heart failure, right? Acyanotic heart disease and heart failure, right? Okay, right, right. Yeah. Right. Okay. We can go to right. Cyanotic heart diseases. We might discuss one or two questions from this, and then we can finish the session. Right. So there was this question: how to prepare for MRCPCH exam. There are several ways to prepare. Now, one way is doing question banks. Right. Question banks. Now, question banks generally will have around, let's say, 2,000 questions, right? 2,000 questions. And there will be at least 2-3 questions for each topic, right? So there is a bit of repetition. So if you refine them, right, at the end, you might get like 1,000 new concepts, which will be fair enough. Only thing, when it comes to question banks, it's like self-learning, right? We need to work on that. There is no one to teach. There may be like 1 or 2 videos in for selected topics, but generally we need to read and understand. So that is something with question banks, right? Or you can follow some structured teaching and then sit for the exam. So that is the other way. So what I generally do is I have 10 classes, like 4-hour sessions, right? In those 4 hours, I usually cover at least 2 areas, say cardiology and neurology, in the 4-hour session. Next 4-hour, respiratory and EIT. Next 4-hour, ethics and genetics, right? And then child protection, like that. In 10 sessions, we finish MRCPCH syllabus, which is enough for FOP, applied knowledge, and then theory and science. So that's the other way how students do. Whatever the way, if you prepare for good 3 to 6 months, this is an exam that we can pass, right? I personally sat for this exam when I was a pre-intern doctor, right? So although I'm a consultant at the moment, I did theory exam when I was a pre-intern. If somebody wanted to know, do I need experience, a lot of stuff? No. You need to, as long as you prepare with some guidance for, say, 3 to 6 months, this is an exam that you can pass, right? Okay, right. So that's about it, right? So we will go to cyanotic heart diseases, right? This one. A 2-day-old baby was found to be clinically cyanosed. The color does not improve with supplemental 100% oxygen in a head box. What is the most likely diagnosis? Cyanosed. The color is not improving with 100% oxygen. Most likely diagnosis. Yes. Yes. Now, here the baby is cyanosed. So a 2-day-old baby presenting with cyanosis. What are the 2 possibilities for a baby to have cyanosis? Either it's a cardiac problem or a respiratory problem, right? Respiratory problems can cause cyanosis. Cardiac problems can cause cyanosis as well. How do you differentiate? You give 100% oxygen. When you give 100% oxygen, if cyanosis disappears, it's a respiratory problem, right? Here, with 100% oxygen, cyanosis has not disappeared. That means the problem is not respiratory. Sorry, problem is not respiratory, so it's a cardiac problem. cardiac cyanosis will not improve with oxygen. So it's a cardiac problem, right? It's a cardiac problem. And then the baby is having cyanosis. So what is this? It's a cyanotic congenital heart disease. It's a cyanotic congenital heart disease. Congenital cyanotic heart disease, in other words. What are the possibilities? Could that be coarctation of aorta? No, coarctation of aorta does not cause cyanosis. This is what it causes radiofemoral delay, all those. Right? So this is not the answer. Pulmonary stenosis, unless it is very severe stenosis, this also generally doesn't cause cyanosis. And we already know ventricular septal defects does not cause cyanosis. So the two possibilities are either it is tetralogy of Fallot or transposition of great arteries. Either it is tetralogy of Fallot or transposition of great arteries. Out of two, what is likely? What is likely? Now, we don't have any more clinical information here to choose what is the more likely answer. However, if you look at the age, this is a 2-day-old baby. The most common cyanotic heart disease presenting at birth. Most common cyanotic heart disease presenting at birth is transposition of great arteries. On that statistics, we can choose the answer as transposition of great arteries over tetralogy of Fallot, right? Therefore, the best answer should be transposition of great arteries. So what happens in transposition of great arteries? You can clearly see aorta. Aorta starts from the right side. You expect aorta to start from the left side. Here, the aorta starts from the right side. Right? Aorta starts from the right side. So the systemic blood flow will be dirty. Right? You are getting blood into the systemic circulation. You name the heart, the brain, everything will get dirty blood. Whereas pulmonary arteries start from the left side. So pulmonary will get good blood and systemic will get dirty blood. Right? Systemic will get dirty blood. That is why they are cyanosed. Right? That is why they are cyanosed. Right. So that's about transposition of great arteries. How do you manage these children? Right? What is the management of transposition of great arteries? Now, they might die if they do not get oxygenated blood into the systemic circulation. So this is aorta. If you want to send good blood into systemic circulation or brain, you need to send good blood into the right side this time, right side. So how do you do that? Right? How do you do that? If you have an atrial septal defect, right? If the baby is naturally having an atrial septal defect, that will be very useful in this condition because this will leak some blood into the right side. That will be very helpful. That will be very helpful. If you do not have, then you have, what is this? Foramen ovale here. You know foramen ovale, isn't it? So you can dilate the foramen ovale by putting a balloon into it. This is called balloon septoplasty, right? Atrial septum can be interatrial septum can be dilated by putting a balloon into that. So that will be life-saving, right? That will be life-saving. Anything else? To send some good blood into the aorta, you might keep the ductus arteriosus open as well, right? You can keep the ductus arteriosus open by starting prostaglandin. What is more easier to do? Suppose you get this question. A 2-day-old baby presented to a district general hospital in Kent, right? Or Canterbury, you name, or Manchester. Baby was found to be cyanosed. He is day 2. What do you immediately do? Yes, immediate management of a cyanotic baby who is symptomatic is to keep the ductus open, right, by giving prostaglandin, right? So you give prostaglandin and then keep the ductus open and send the baby immediately to a cardiac center. There, what will they do? They might dilate the atrial septum or foramen ovale by doing balloon septostomy, right? Balloon septostomy. That can be done. But that again is just a temporary measure. But what is the best management? The ideal management should be you take the aorta off from right-sided chambers and implant or connect the aorta to the left side, and you take pulmonary vessel from the left side and you connect that to the right side, right? That is called arterial switch operation, right? Arterial switch operation is the definitive management. But before that, what do? You can do septoplasty. Also, you can give prostaglandin. So that's the immediate management, intermediate management, and definitive management of transposition of great arteries. What do you do first? Prostaglandin. Second one, balloon atrial septostomy. Third one, arterial switch operation. Right. And what is the most important message? Transposition of great arteries is the commonest cyanotic heart disease presenting at birth. At birth. Right. That is why we chose that as the answer over etiology of fellow. Right. And some more things. Now, transposition of great arteries, unless you have these defects, right? ASD and all, right? Plain and simple, transposition of great arteries will not cause murmurs. Will not cause murmurs. Right. If you were given a different scenario, a baby was born with cyanosis, no murmurs were found, then it could be transposition of great arteries. Right. Okay. Right. We will do 2 more questions and then we will finish the session. A 2-day-old baby was found to be cyanosed with respiratory rate of 70. Upon auscultation, second heart sound was found to be loud, no murmurs. Baby responded to mechanical ventilation. Mother is diabetic. Which statement is false regarding this child? Which statement is false regarding this child? Right. Okay, now this is a cyanotic baby. Cyanotic baby. Day 2, right? No murmurs, right? No murmurs, cyanosis, and day 2. So what is the most likely diagnosis? This is likely to be transposition of great arteries, right? This is likely to be transposition of great arteries, right? Now, if you know that, what is the likely answer? An IV infusion of prostaglandin should be started immediately to maintain the patency of ductus arteriosus. Is that correct? Yes. Transposition of great arteries, keeping the ductus open is beneficial. So this is correct. Right. There is a place for balloon atrial septostomy. We just discussed. Yes, that is beneficial. Right. And then the corrective procedure is done within 1 to 2 weeks. Yeah, when you do corrective procedure, that would be definitely beneficial. So that is also a correct option. Could be associated with DiGeorge syndrome. DiGeorge syndrome could be associated with heart problems. Transposition of great arteries is one of them. So that is correct. Chest X-ray may demonstrate snowman appearance. Is that correct? Is that correct? Do you get snowman appearance in transposition of great arteries? No. Why? Snowman appearance occurs in total anomalous pulmonary venous drainage. Snowman appearance is seen in total anomalous pulmonary venous drainage. So this answer is wrong. Right. Okay, so diagnosis is transposition of great arteries because that's the commonest cyanotic heart disease presenting at birth. Right. And then it does not cause a murmur. And cyanosis and tachypnea is more common. And second heart sound could be loud and single, right? Because the pulmonary blood flow is high. Murmur may be absent, right? And then that is common in babies born to diabetic mothers. And this could be associated with Bigelow syndrome as well. So we need to give prostaglandin to maintain the patency of ductus arteriosus and to improve oxygenation, right? And later, you might go for Rashkin balloon atrial septostomy, right? And then we don't need to know more details about these procedures, but you do this routine procedure to correct all these problems and bring the arteries back to their normal position once the baby is fairly stable, right? And so the diagnosis here should be so the wrong answer is TAP-VD because wrong answer here is snowman appearance because snowman appearance is not seen in transposition of great arteries. Snowman appearance is seen in total anomalous pulmonary venous drainage, right? So that's the answer. That's the wrong answer. So that is the answer for the question, right? Okay, the last question that we will be discussing today, right? Now remember, now we did like 12 questions if you talk about numbers, right? We could have even done 50 questions over 2 hours, but what I wanted to do is a lot of concepts, right? When we understand concepts, the pathophysiology and all, we can apply to those questions. So with the knowledge that we have just gained during this discussion, you should be able to do hundreds of cardiology questions by now, right? Right. 6 months old baby was found to be having central cyanosis and systolic murmur, best heard at pulmonary area with associated epigastric pulsation. No cardiomegaly. Growth and development is age appropriate. Rest of the examination is normal. ECG shows right axis deviation. Most likely diagnosis is 6 months, cyanosed, systolic murmur at pulmonary area, epigastric pulsation. Growth is okay. ECG, right axis deviation. Yes. You can see a lot of correct answers. Yes. Now, what are the possibilities? Could that be ASD? No. ASD, atrial septal defects, does not cause cyanosis, so that is wrong. Right. Then could that be TGA, transposition of great arteries? No, we have just discussed that they present soon after birth. Presenting at 6 months is very unlikely. Plus, usually this does not cause a murmur. This does not cause a murmur. Right. Then what are the possibilities? Could that be tetralogy of Fallot, TAP-VD, or tricuspid atresia? Right. Now, if we go to tetralogy of Fallot, just to have an idea. So this is tetralogy of Fallot, right? Why is it known as tetralogy? Because there are 4 associated abnormalities, right? 4 associated abnormalities. What are the 4 associated abnormalities? Now remember, tetralogy of Fallot is a very common MRCPCH clinical case, right? MRCPCH clinical cases, cyanotic heart, cyanotic child in your cardiovascular station. That could be tetralogy of Fallot, and there will be 6 minutes for you to examine, and then there will be good 3 minutes of discussion going on. During that discussion, they might ask pathophysiology, anatomy, management, investigations, complications, all those. So it's a good idea to have a general understanding about what is happening here. So tetralogy of fellow, the four components are there. They have large VSD. There is a large VSD. Then overriding of the aorta. Usually aorta should open to left ventricle, but here part of the aorta will be open to the right ventricular side as well. You see, aorta can get blood from the right side and left side both. When aorta gets blood from dirty chamber, that is where cyanosis starts, right? When you have overriding of aorta, when aorta goes to the right side, right? Aorta is legally bound to left side. Now he is putting his hands to the right side as well. Then what will happen? Right-sided people will start compressing. That is why you get some pulmonary stenosis. So there is pulmonary stenosis, overriding of aorta, VSD. When you have pulmonary stenosis, right ventricle will suffer a lot to send blood out. So there will be right ventricular hypertrophy. So what are the four features? Overriding of aorta, pulmonary stenosis, VSD, and right ventricular hypertrophy, right? So those are the four features, right? Now, when you have tetralogy of Fallot, of those four features, what are the clinical manifestations? Because of pulmonary stenosis, they can have an ejection systolic murmur, right? They can have an ejection systolic murmur at pulmonary area, right? That is something that you see, right? Number two, due to thickened right ventricle, you will start to feel epigastric pulsation. At the epigastrium, you will see that there is some pulsation happening. Epigastric pulsation is common. And because of this blood mixing, the baby will be generally cyanosed as well. You will see this kind of dusky appearance around the mouth, right? This kind of dusky appearance around the mouth, right? Okay, now you see, with that knowledge, if you read the question again, you see systolic murmur bested that pulmonary area with epigastric pulsation, right? Epigastric pulsation. And when you have right ventricular hypertrophy, there will be right axis deviation as well, right? Right axis deviation as well, right? So the best answer should be, could that be tetralogy of Fallot? Yes. Tricuspid atresia, we have not discussed. We might discuss that in a different session. However, in tricuspid atresia, what happens is there is no well-formed tricuspid valve. Therefore, what happens? You are not getting blood from right atrium to right ventricle, right? Right atrial blood from the top chamber, blood is not coming to right ventricle because the valve is not there. Then what will happen? Right ventricle is not getting blood. So the right ventricle will be rudimentary. Right ventricle will be very weak. Therefore, you do not get right axis deviation on ECG, right? Tricuspid atresia does not cause right axis deviation. So that is why tricuspid atresia is wrong here. So that is wrong. Right. And then TAP-VD, right? TAP-VD, total anomalous pulmonary venous drainage. Usually, this causes cardiac enlargement or cardiomegaly. Here, there is no cardiomegaly. If the cardiomegaly is not there, TAP-VD is unlikely, right? TAP-VD is unlikely. So the best answer should be tetralogy of Fallot. Right. Okay, tetralogy of Fallot. Right. Okay. So yeah. So that finishes cardiology discussion.